My name is Dr. Andrew Wei. I'm a haematologist from Melbourne, Australia, and I'm here in this beautiful location, Estoril in Portugal, and I'm attending the European Society of Hematology meeting on acute myeloid leukemia. I've been asked to discuss today what I think is going to be the role of targeted therapies in the future of AML. I think we're really entering an era of enormous change, and really the future strategies are only just starting to become apparent. Some of the major challenges which I think we face currently are firstly this new wave of new therapies and the potential that some patients may have access to more than one therapy, and putting the question on the physician and the patient how to choose between now more than one therapeutic option. The second challenge is that some of these therapeutic options are primarily designed for older people with AML, but the question is, could these also be applied to some younger patients who may spare exposure to intensive chemotherapy? The third is that we're increasingly recognising that acute myeloid leukemia is a disease which undergoes dramatic and constant change and evolution, and that the old adage of just characterising the disease molecularly at diagnosis is now no longer appropriate, and really at each progression we need to recheck, reanalyse and reassess what the leukemia is looking like. And really the future, I think, will be to recognise that AML is an adaptable disease and our therapy has to adapt with it. So in light of these dramatic challenges, the question is, how do we therapeutically go forward? We have a number of new therapies which are showing great promise. However, none of these therapies on their own will necessarily be the complete answer or be curative. Our options are either to increase the intensity of the treatment, as an analogy using a bigger hammer. The alternative is to combine many therapies together, and the analogy would be to use many smaller hammers in combination. The third option is to perhaps recognise that AML is infinitely malleable, and that perhaps clonal evolution is almost an inevitable consequence of patients that are destined to relapse, and to perhaps use more surgically targeted hammers sequentially when the patient needs it. And so today, my talk, I'm going to discuss a new concept of a trial which is aimed at trying to monitor patients using new minimal residual disease technologies, and trying to preemptively strike these new clones as they emerge before the patient becomes unwell, and to accept that we may have to do this in a recurrent and recursive manner, but that perhaps by doing it in this way we can spare patients unnecessary toxicity by using too many therapies or too intense therapies at the beginning, and still end up with patient that relapses at the end of the day.